Welcome. I am Nancy Wagner. I am a CWRU Francis Payne Bolton Nursing alum, class of 2009, Doctor of Nursing practice graduate. I'll also add that I'm also the former dean of the Youngstown State University College of Nursing as well. And I am here representing the Alumni Association of FPB, and I'm sure that we are really pleased to be here. This has already been such a fabulous weekend. I know that nursing, medicine, dental, we're all here together, and we have parents and students and alumni and friends, and it's so great to be here all together collaborating with this very special topic of AI. As I said before, I'm delighted to welcome you here, our annual homecoming tradition with homecoming and parents' weekend and the football game and all of these sessions certainly creates a commitment to this partnership here in the building, especially in this building at Case Western Reserve University. We're here in this space for all three areas. We're come together as a team-based collaborative, and we're looking at our health careers and the issues that we're all dealing with in all of our health careers. The state-of-the-art facility, if you haven't taken a tour yet, please do. It's amazing. It embodies the spirit of this collaboration. There was a lot of thought that went into this building, and we have meaningful collaborations across the disciplines. This morning, our topic is the role of healthcare providers in the age of artificial intelligence. And while some of you may be very already expert in this field, some of you probably are thinking, I'm glad I'm here because I have no idea what this is about. But a lot of people feel that way, especially related to the art of healing. We are pleased to have three distinguished faculty who are leaders in their fields and will share their perspectives into the impact of AI in dentistry, medicine, and nursing. To begin, I'd like to introduce our first panelist. From the Case Western Reserve School of Medicine, it is my pleasure to introduce Dr. Leah Logio, the Vice Dean of Medical Education and Director for the Center for Medical Education, where she serves as the John L. Caughey Jr. Professor of Medicine. She oversees our MD programs, the Physician's Assistant Program, and the National Network of Anesthesiologist Assistant Programs. That's a big job. Dr. Logio, please come up. Thank you.
Thank you. I got it.
Oh, sorry. There we go.
Welcome. It's delighted to be here with you this morning. My first comment is a disclaimer, which is I am not in any way, shape, or form an expert on artificial intelligence or anything related to artificial intelligence. But I am a curious person by nature, and I'm very interested to try to understand how this may be valuable and how we need to guard ourselves against some of the risks that may be coming in the world of artificial intelligence. So this is, my background, which is what was already said in the introduction. But in general, I'm involved in helping teach the next generation of medical doctors and physician's assistants and certified anesthesiology assistants. And they're all learning their trade of taking care of patients in whatever spectrum that they're looking for. And so my main slide is this one, which is that there are some really important distinctions between the left side of the slide, which is the healthcare delivery space, and the right side of the slide, which is the education learner space. But they are, as the picture implies, very different but very interdependent. So my dean likes to say, Leah, we have to train our new providers for where the puck is going to be in the next 5 years. Well, I don't know that anybody can predict where the puck is going to be in the next 5 years as it relates to AI and the healthcare delivery system. But I'll share with you some of my reflections, which is on the healthcare delivery side, there are a lot of potential positives. And those positives include improving diagnostic accuracy, personalizing patient care, because these artificial intelligence robots, if you want to call them that, can actually customize their approach to an individual patient. And my hope and dream is that it would also streamline the workflow of providing care. So I am a general internal medicine physician, and I will tell you that I remember when the electronic health record came out, and the promise was we were going to have so much extra time because the electronic health record was going to help us. That's not exactly how it worked out. So I am also, I'm cautiously optimistic, but maybe I have more weight on the caution based on the electronic health record conversation. So if you haven't heard about Ambient Scribes are an app on your phone that you walk into the patient's exam room with, and you turn it on and you say, "Hi, what are you here for?" And they talk to you and you talk to them and you examine them and you say things out loud about what you're doing and what you found on the heart exam and what the rash looks like and all the things that you're doing when you're talking to a patient. By the time you walk out of the room, the Ambient Scribe has actually written a note for you. And the note is already in the format you want it to be in, and you can edit it and you can make it better. Well, that sounds pretty miraculous, because now all of a sudden my pajama time on Epic is going to be decreased, right? You know exactly what I'm talking about, right? So, but there's some downside to that. The Journal of the American Medical Association had an article not that long ago about how the Ambient Scribes, very intentionally, they're coded to do this. They sanitize the note of any chit-chat, any personal information. "Oh, you just got back from Portugal. How lovely. Oh, I'm sorry your mother died." Anything that was considered personal got taken out of the note. That's actually highly valuable for me, because I'm going to see this patient again, and I'm going to want to remember that their mother died to say, "How are you doing? How's your grief?" Right? And so we have to balance that. So Ambient Scribes are a great promise, but we have to put some guardrails on it. Patient portals, you've probably already seen this, but there's lots of information about how patients have access to their information. Sometimes that's good. Sometimes every red number, even if it's monocyte count, is, something for them to stimulate a phone call with or a portal message with, and you're like, don't worry about your monocytes. But the other thing is that chat bots and robots can respond to those messages for you. And the data suggests that the bots do better, because I'll say, "Don't worry about those monocytes," and the bot will say, "I understand it's red and it makes you nervous, but don't worry about it. The monocytes are this and this and this." And they have all the time in the world to provide a very strong background information. They're graded by the patients as more empathic because they take more time. They don't get burnout. They don't worry about pajama time. They're bots, right? Imaging, I think in the pathology world and the radiology world, there's a lot of information about how they can find things faster, sooner, quicker, easier, but they can't, if they get it wrong, they can't be sued. So there's gonna, again, have to be some guardrails about those kinds of activities. One interesting thing is around procedural assistance. There was actually a really interesting study out of Poland looking at colonoscopies, and providers of proceduralists for colonoscopies had a certain % of finding polyps. Well, then they used an AI-assisted monitor that tried to find changes in the mucosal lining and highlight for them, and they found more polyps. And then the providers who were using the AI-enhanced monitors tried to do it without the AI-enhanced monitors, and they found half as many polyps as they did before they ever used the AI-enhanced polyps. So they de-skilled because of their reliance on the AI, which may not be so good because, as you all know with the electronic health record, sometimes it goes down. So we still need to be able to do what we need to do. And then, of course, patient education, data exploration, looking at big data, lots of possibilities and lots of positives. I worry about the stuff on the right side of the screen because I really want our students to learn medicine deeply. I want them to be able to think like a doctor. I want them to be able to really think about a challenging patient and understand all the interdependence of what's going on with them and to not take a shortcut. I know, as someone who's in medical education, that when you're learning something, it's a little uncomfortable. Have you ever learned a foreign language? It's uncomfortable and it's not fast. It has to take time and you have to practice, and there's this concept of deliberate practice to get where you need to go. The students don't like to be uncomfortable, and shortcuts are fast and easy and quick and make it nice and neat, right? And in today's society, that's sort of something we value, right? To make it quick and easy. So we're really trying to work hard on how do we at least teach them competencies around AI, limitations of AI, the bias that's embedded in some of the data and how the data is stored in AI. We don't want them taking shortcuts because we don't want them to shortcut their deep learning. But there's a lot of potential positives too. I can now personalize their education. We have a project that's called the Reflective Clinician. It's an app on their phone that once they get into the clinical space, if they feel a little weird, like I'm in pediatrics, I've never been around kids before, they can talk to the app and the app will sort of reflect with them very personally because it's a very safe space. And it gives them a sense for this sort of personalized education. We can actually even try to figure out, looking at the data, what does this one student need and how is that different from what this other student needs, instead of having everybody get the same thing. The same is true in feedback and coaching. We stopped doing oral exams because as the medical schools got bigger, it was hard to do that. But with artificial intelligence, we might bring back the oral exam. Haven't decided about that one yet. I think what's really important for us is that we really think long and hard about what are the really important skill sets that must be in our clinicians moving forward. I also think it's important to say that nowhere will a bot replace a clinician, because I think the human touch and the human connection is a vitally important part of that therapeutic relationship. There's actually a book that's recently been published by Alison Pugh called The Last, I don't think I wrote it down, The Last Human Jobs. And she talks about connective labor, which will never be able to be replaced by robots. I think we really have to think long and hard about what we're doing, why we're doing it, make sure our least experienced aren't the most susceptible to the shortcutting, and really think long and hard about optimizing the good and minimizing the bad. This isn't working now. This. And it won't be easy. Let me see if this will play. Oh, it didn't play. Hold on a second. Let me see if I can get it to play. Oh, it didn't play. It's a very funny video of a penguin that gets sidelined by another penguin, and it won't be easy. So that's my challenge. I'll let Nancy come up, and I'll hand this off to you.
See if it works for me.
Thank you very much. Thank you for addressing some of the things that we're all thinking about every day about personalized care. Next, from the School of Dental Medicine, I'd like to introduce Dr. Scott Pelock, Associate Professor from the Department of Comprehensive Care. He teaches clinical pharmacology, CAD/CAM dentistry, and implant dentistry with a special focus on the use of virtual reality and artificial intelligence in dental education. If you know nothing about virtual reality, next time you see headsets it's actually a very cool thing. So so take advantage if someone wants to hand you the headset. It's really an exciting technology. Thank you.
Thank you. Just a little bit more about myself. I'm also on Case Western's AI Governance Committee, making the rules and regulations and the bylaws of how we're going to use AI in education here. So I've got a little bit more information. That's a brand new image that I actually generated with AI just for this lecture. AI is not new, but artificial intelligence as a term was coined in 1956. It's just been in the last 10 to 15 years that it's gone into the healthcare professions. And in that amount of time, it has grown exponentially. It's absolutely crazy how many things have been going on out there. How long do you think it's took for 25% of the US population to get onto electricity once electricity was available? 48 years. Okay? How long for the internet to get to 25% of the US population? 13 years. How long for ChatGPT to get to 25%? Any ideas, any guesses? 5 days. 5 days for ChatGPT to hit 25% of the US population. That's how much AI is growing. Now, AI, there's just some of the lists on the left-hand side there of, different types of programs that have been available. I gave a lecture in artificial intelligence to the Dental Symposium in September, and the numbers you see on the right have grown since that time. And I had the FDA listing for how many FDA-cleared artificial intelligence enhanced devices. In August of 25, it was at 1,196 and 42 dental. In September, just last week I looked it up, 1,248 and 42 dental. Okay, in just that 1 month period. How's it going to affect dental jobs? Okay, those that are safe from AI, I think oral maxillofacial surgery, pediatrics, periodontal, prosthetics, the hands-on type things, we're going to see a lot of folks, and those lines are going to be safe. What's not going to be so safe? Oral radiology, medicine, orthodontics. I mean, we're seeing so many types of things nowadays that are being done with AI. And the question is, well, what's it going to do to the general dentist? All right. Well, some of the things it can and cannot do. It can transcribe notes. It's supposed to increase the recording efficiency. It offers treatment education, detects radiographic differences. We'll talk about that. Increases the accuracy. We can talk about that. All right. It cannot supposedly diagnose. So many people are out there saying it's not diagnosing. It's offering a tool. It's offering you a way of getting your work done better, okay? It can help you. It can't really do the treatment plan. You have to do the treatment plan. It can't cut a crown, or can it? Anybody know who this is? He's got a pretty famous son. This is Edward Zuckerberg, Mark Zuckerberg's dad, okay? And with Mark's money, they came up with Perceptive. Welcome to Perceptive. Cutting a crown. Okay? So now not only can we cut the crown, but with CAD, we can build the crown to the cut we're making before it's even done cutting. Okay? There are issues with this. Not going to get into that. That's for a longer talk and a longer seminar. But there it is right there, all right? Pros for AI: improves diagnostic accuracy. It helps with early detection. The 3D imaging and treatment planning, radiography is really being benefited from this. It's finding the information, it's presenting the information faster for us. We can process it faster. We can do personalized care, as you said, for each individual person, okay? We've got Pearl Dental out there. I'm sure you've heard about this. Pearl is one of the first ones out there. They got the first FDA clearance, and they're in 120, and it didn't play. Oh, that's all right. Anyways, let's see if it'll go backwards. All right, Pearl Dentistry is the one that you see that has the graphics that show you that shows you the decay, shows you the periodontal pictures, okay? They're the first one to come along. Now we've got Overjet and at least 24 other companies that are providing this care out there. The problem with AI is it's based on the quality of the radiograph in which you take, and those are not standardized across every office. You got equipment variations, you got technique variations, you got setting variations. Your assistants, your nurses, or whomever may not be able to get the exact same radiograph that these databases are set up on. The data sets in which they're based are very limited. Even though they say they're called a large language model in which this information is being extracted from. These language models, for example, Pearl has only 800 sets of radiographs in which they developed their technology to look for caries and periodontal. Well, I don't think 800 sets of radiographs is a very large set of data to pull that information from. And it's idealized data in and of itself, as we said. The data is not always the best. The techniques and everything can vary on that. So they're also proprietarizing the data sets. So Pearl's data sets of radiographs and Overjet's may not get shared. So they may look at different data sets and come up with different information. It's not giving the comprehensive overall exam, and the labeling still hasn't reached the level that we need it to be very accurate. There is a bias towards how the data is trained. The people who are training this may or may not have experience or are experts in the data in which they're developing it. So you've got some of that inherent biases there, and then being able to transfer from Axiom to Epic to whatever other electronic patient record system we're using with, that's just not there yet. So these so-called expert systems, we're seeing a lot of differences in the levels of potentials, treatment plans, and options that they're giving us. There's a great potential here, but it's just not there yet. If you look at the reference down on the bottom, there is a paper put out by somebody you might know. I was only second author. We actually did a study with periodontists, and we took 3 cases, and we took all the perio faculty and all the perio students, residents, and then about 30 perio practitioners outside the school, gave them 3 cases, and asked them to come up with disease diagnosis and treatment options. And of the 45 participants, I think we got 42 different treatment plans. So there wasn't a lot of agreement among the experts. Interestingly, the residents had almost a 90% agreement, which was double what the faculty had. That was a very interesting position there. The consistency that we're seeing, part of the problem is what's driving the data in the background is in this black box. We don't know what's being programmed or how it's being programmed, for those of us not in the know. So you're depending on somebody else to develop that type of diagnosis, the caries detections, the perio detection in the dentistry, okay? Until that comes out, until that's standardized, we're not going to reach the full potential. And believe me, I think there's a great potential here for AI, but it's just not there. I know it's going crazy. It's absolutely amazing how fast it has grown, but it's got a long way to go. We've seen the context, okay, of if that patient is somebody from a very poor socioeconomical group, they may not have the same access to dental care, but they may have immaculate teeth because of the way they take care of it. And then you may have somebody else from a totally different area that is just, it doesn't relate back and forth. So it can't take into context your patient at that time and what they're doing and how they're taking care of themselves. So it doesn't have that ability to do that. And as you said, the over-reliance, okay? I quoted the same article you did, 20% reduction from that colonoscopy study in Poland, okay? For those who actually, yeah, that was a great article there. All right, then you got the ethical and the legal challenges here. Who's going to be, accountable for errors on it? It's not going to be the people who are programming it. Okay? You have to be the one that is actually going to make the diagnosis and make that treatment plan. It's a tool. It is not a doctor. Okay? And here's another issue. How do you give informed consent if you don't know how it's checking that information? So there's a big step there where the informed consent you may give isn't comprehensive for what you're using as a tool to work with it. Data privacy, if this information is being shared out, there is no regulations on this whatsoever. Okay? And that's the big thing. There is no regulations whatsoever. Cost and accessibility, we'll see it in the big clinics and the big practices. We're not going to see it in the smaller places. And if we don't see that, how do we get that standardized across all the different people that we're going to be working with? So the dentist, and I say dentist here, and I should have changed it, the healthcare provider has to be the final decision maker. Okay? This is a quote I got from the Office of Health Information. Successful dental management needs to have an acceptable definition of standards. We don't have definition of standards. If we don't have the standards, then right now it's just a toy that can help us further down the line. Okay? Thank you. Hit the next one. There you go.
Will be an opportunity at the end to ask all of them questions, so please save those. Thank you very much. Very interesting. And last but not least, from the Francis Payne Bolton School of Nursing, I'd like to introduce Dr. Kylie Meyer, gerontologist, assistant professor, and co-director of the University Center on Aging and Health. Her research program focuses on digitally delivered psychoeducational interventions to support family caregivers in multiple domains, such as complex medical nursing care, healthy caregiving relationships, and financial well-being, often integrating digital tools to promote nursing. I'm sure this topic affects all of us as our parents and our loved ones are aging, so we're anxious to hear about your focus on that. Thank you.
All right, can you hear me now? Good. All right, well, thank you again for having me today. And I just want to start off, well, one, make sure I know how to click forward. There we go. I want to start off by saying I came into AI kicking and screaming. I was not looking to go use AI tools as a part of my program. However, we found that this was a solution to a challenge we were having in delivering a psychoeducational program for family caregivers. And so I do want to preface this with my talk today, a lot of it won't directly be about AI, but what I want to do is provide some context. Why did we start to turn to AI as a tool? Because we didn't start off with a solution in AI looking for a problem. We had a problem and realized AI might be a solution for us. So a little bit about my background here. Again, I do intervention programs. I study, test, develop intervention programs to better support family caregivers to people who are living with dementia. How many people in this room have been a caregiver or are a caregiver? A couple. So you know what I'm talking about here. And one of the things about caregiving that we know, people know that it's really stressful, it's really challenging. One of the challenges that isn't talked about so much is it's really expensive. People face really high out-of-pocket costs related to caregiving. These are things like the over-the-counter medications you might pay for that aren't covered by insurance. These are the sticky socks that you might need to get around the house. These are the grocery costs that when your family member comes and moves in with you, you're not going to charge them separately for groceries. Those get added to your bill. You put those all together. So those little things that accumulate over time. We're going to go more into that, why we're focused on this topic, but I wanted to give you an overview about what the focus, the challenge we were trying to solve before we got into some of our tools here. One more piece, one more thing to say in terms of definition. Psychoeducation, it's kind of a funny term. What this is with family caregiving is it's education, so we're providing information to family caregivers, right? But we're doing it in a therapeutic approach. We're trying to build skills, we're trying to build ways to help people manage some of the stress around finances and caregiving. So The Confidence Program is a community-based program I'll be talking about where we actually didn't start with AI, as I've mentioned. So you can see it was only about halfway through in 2023 that we refined an existing program to integrate AI. And the reason we were trying to do that is to solve this problem. So the Confidence Program was made to reduce financial strain among family caregivers, but we had to refine the program to help caregivers engage in psychoeducation because caregivers are busy. They're really busy. So when we asked caregivers, as we did, to attend 5 group-based Zoom sessions once per week for 5 weeks, that they didn't have time. They weren't attending as much as we hoped that they would. So we had to find a solution to that. So a little bit more about the topic. One of the things about the Confidence Program is it is culturally tailored. So if you look at family caregivers, they're spending about $10,000 per year in the out-of-pocket cost related to care. That's a lot of money. But it's not equally distributed, some of these harms, right? If you look among family caregivers in general, they're paying about 26% of their annual household income on these out-of-pocket costs. And we've mentioned some of what those are, right? If you look at Latino and Hispanic caregivers, that's closer to 47% of annual household income. I'm not going to go too far into why that is, but just kind of briefly, in the US, Hispanics and Latinos are providing more intensive care. They're providing more hours of care. So that is a part of the story why some of those costs might be higher. So why did we culturally tailor the program? A couple reasons. Culturally tailored interventions are actually found to be more efficacious. And you can imagine this with any kind of tailoring, right? So if you're looking at content in an education program that maybe reflects more maybe what you're experiencing in your family, that's going to resonate a little bit better, right? And so that does play out in the data that these tailored programs are more efficacious. And we also decided that if we were going to build a program to address financial strain and it didn't benefit Latino family caregivers who are the most financially distressed from this figure you can see, then it didn't work. If it doesn't work for the at-risk group, it's not going to be a good solution, right? So I just wanted to answer some of those questions before diving in. So again, the original Confidence Program that we tested we started developing in 2020, ran through about 2022. This was a 5-week program I mentioned. We had a facilitator who was at a community-based organization in Southern California, and they traditionally had been delivering some of these education programs. This was just one more program for them to deliver, so they were quite seasoned. And the program included these group-based sessions, including some didactic information, as well as an opportunity for peer learning and discussion. We had caregivers use a workbook in between sessions. So after a session, they could go do some readings. They had some recommended resources that they could review, as well as practice exercises. And one of the things I want to say with this, especially when we're talking about financial well-being, this was not the program to finger wag at people and go, you need to save more money. That is not effective and it's not helpful for anyone. What we wanted to do is help family caregivers to try to displace some of the out-of-pocket cost of caregiving. Things like how do you navigate community resources, such as finding resources through the Older Americans Act programs to maybe get low-cost home modifications rather than paying for that out-of-pocket. We also did a little bit on money management. So you probably already know how to use a budget, right? But when you start caregiving, you just start doing, you just start trying to manage. So how can we think about a tool that you might already know and apply it to a new context to help you better reflect on how to use this as a tool to make decisions about financial well-being? And so that was the first program. And we did actually find that it reduced financial strain. So we tested it in a pre and post test program. And we saw, we surveyed caregivers, they did the intervention, then they surveyed them again. And they did have a reduction in financial strain. That was really good. What was less exciting is we didn't see the attendance that we wanted. So I mentioned that we had tested this in a community-based program. People could choose to be in the study. They could choose to just do the program itself. That was fine. And the first number here, that kind of first bullet point, we saw that of those people who registered for the program, only about 50% actually attended one session, which I was really disappointed by at first. And then the community partner we were working with explained that's pretty normal. People get busy, so they register for something online. They get busy, they can't attend. That might have happened with some of our attendees today. That happens, right? The more concerning thing was the second number. Caregivers only attended about 3 out of the 5 sessions of those group-based sessions, and we thought we could do better than that. if we can get people to attend more sessions, we might have better efficacy in the program. And that's finally, I'm getting it to AI, that's where we land on AI as a potential solution. So this is a program pictured here representing the NuviCare app. This is a program that was developed by a company called Amicus Brain Innovations. I had a colleague who was working with the founder of this program. Her name is Chitra Dore, and she was an IBM fellow. And she started taking care of her mom and thinking, hey, we're using all these tools at IBM. Why can't I take those tools and apply them to family caregiving? Why can't I help family caregivers quickly find accurate information about how to manage the financial cost? She was not focused on financial well-being. She was focused on things like managing behavioral symptoms of dementia. So she created this program, NuviCare. You could download it today. It is commercially available. And so we started talking about how this could be used in a secondary use capacity to complement the Confidence program. How could we use this to provide another layer of support to what we already had in psychoeducation? And so what we did is we worked together to take the Kiko, the digital AI assistant, and trained it on the workbook that we gave to caregivers. We trained it so that when a caregiver actually could text, you can text the AI digital assistant and say, hey, Kiko, what is this Medicaid spend down thing? And what is the stipend that maybe caregivers could get from the VA to get paid to provide caregiving? Because that's pretty technical information. So if you didn't have to flip through the entire workbook and get the exact information you needed, that might help you better engage with some of the content. We also had some text messaging features such as reminders. So reminders to attend the group-based sessions, to do some of the recommended practice exercises. Let's see, anything else? There were other content in the app. I'm not going to go too far into it just because of time's sake, but there were some other features as well. So what we found is, again, we ran a pre and post test study, and we did see, again, reduction in financial strain. Yes, that was great. However, we actually didn't see a huge amount of change in attendance. So we dropped the sessions from 5 sessions to 4 sessions, and people only still attended about 2.4 out of 4 sessions. So that was a little bit of a bummer. We thought that people might engage more since they had this extra tool. But a couple of things that I want to, I'm sorry about the skewed PowerPoint slides here. A couple of things I want to mention. So of those, the caregivers who registered, about half of them registered for the app. We didn't force people to register for the app. And again, this was delivered in a community-based program. So this is probably reflecting more actual use than an idealized kind of researcher-controlled setting, right? This wasn't a proper randomized controlled trial. So half of people, which is pretty good. Not everybody's going to take up an app like this. And then this is, if you might be familiar with a run chart. So down here on the x-axis, we have the cohorts. So we had 8 cohorts who participated in the program. So these each represent a group. And on the y-axis here, this vertical line, that represents the average number of sessions out of 4 that they attended. So we had a range of 2 sessions to 3 sessions that these cohorts participated in on average. And this yellow line is representing the percentage of people in each cohort who actually registered for the app. And so I don't know about you, I don't see any pattern there. However, if I did run this through a bivariate analysis, there was a slight correlation where if you registered for the app, you were more likely to attend more of these group sessions. So did AI help increase our attendance? Maybe. I'm not going to say that so strongly, but it's possible, right? I'm actually going to skip this slide and skip over into some lessons learned. A couple of things that we learned from this experience. It was really interesting to me. We thought caregivers were going to register for the program and then register for the app right away. That didn't happen. They registered for the program, attended the first session where we did a walkthrough on how to use the app, and then 7 days later, they registered for the app. It took them some time to warm up to this idea. And it took them some time to take on some of the tools. And it makes sense when you think about it. So here we are talking about this really tough topic, financial strain, which is stressful enough to think about. And then we said, hey, we have this app that we want you to learn too. You might never have used AI, but we want you to learn how to use AI. And we had a couple other features in there that we had as well, a community-based forum, a digital space on the app where you could do some of the practice exercises. Well, you only have so much time, so caregivers didn't have time to invest in learning the tool. And so if I were to do this again, I would simplify the app, keep it really simple, maybe just keep it to that text messaging-based component. The other thing I would do is provide more time for people to learn. So maybe it's not going to be a brief intervention, maybe it's not going to be a 4-week program, maybe it's a 6-week program where people can imagine new ways of using these digital AI tools that they weren't thinking about at first. The other thing that was really important to us was team communication. We do feasibility studies to find out unexpected challenges, and boy, did we find some. That's the nature of human subjects research. So I told you that we were culturally tailoring this program, right? And that's one of the reasons why a text message-based program was really good for us. Latinos in the US are more likely to be dependent on their smartphones to access the internet. So that was a good way, because this was a text messaging focused app, this was a good way to make this program accessible to our community. What we hadn't thought about is when people logged on to the Zoom sessions, they were logging in on their phone, right? However, we had a walkthrough on how to use the app, which they also needed to use their phone. I'm seeing nods. I'm seeing some people see the problem. You had to flip between the Zoom and the app. So a lot of challenges. So we needed to be in communication with our interventionists to make sure we recognize some of these challenges. So I'm going to stop there, but I really appreciate your attention today and happy to answer questions. Yeah.
We're going to invite our speakers to sit on our benches, our stools up here, and answer questions. And we certainly would love to have some audience participation. If you have any questions, we will certainly hand you a mic. There have to be questions. Go ahead.
Hi, good morning. This is for the dental. I know you mentioned that AI is going to affect a lot of specialties, but I did not see endodontics in there, so I'm wondering what your take is on that.
Endodontics, I think, is going to be one of those specialty programs that, because of it's going to be two-tiered the way I see it. The endodontists are still going to be required to be part of the dental care team. I think all the specialists will be part of the dental care team. But the finesse to do that type of work, I just don't see in the near future the control built into anything robotic. However, the AI itself will help identify the different abnormalities that may be seen within the tooth that could assist the endodontist to do their job better.
Hi. So we've seen that with electronic health records, a number of providers that were long in the tooth decided to retire than to adopt it. And now I'm one of those providers that's long in the tooth, and I'm looking at this and I have zero interest in, what's going to happen to my generation and us that have a little bit of experience.
I think there needs to be an easy button. I think the electronic health record was never an easy button. It still isn't an easy button. I mean, our Cleveland, everybody but the VA has Epic, but they have their own version of Epic, and so it's never a plug and play kind of thing. I think what needs to happen for it to be high value is that it is actually an easy button for the providers. And I actually think the providers have to lead the way for what that looks like, which somebody will do that, right? And then they'll try to create the plug and play. I hope that it actually brings back a little bit more joy and meaning into medicine, because that's what's missing in all of the tech stuff. And my hope is that if we shape the clay just right, we can actually get back to the heart of what we do as clinicians.
If I could offer a follow-up to that, I think that your long tooth generation is going to be needed for quite a while. We still have a large majority of the population who are Luddites. They don't want it either, and they don't want to go someplace that may be the only way they get it. So as we transition our newer generations of healthcare providers, those people coming up will be treating, I think, the folks that are more acceptable of that technology. There's going to be many years still where people receiving it won't necessarily be comfortable getting that directly. Personal opinion.
And I'll just say, I think forums like this are important, especially to get the disciplines talking. One of the challenges we had with, and I'll go back to the kind of easy button analogy, our technologist, she was amazing, but she wanted to give every bell and whistle to this app. And what really we should have been doing is saying, what does the caregiver actually need? So having that communication saying, wait, let's keep this streamlined to actually address the need that we have, whether you're a provider, whether you're an end user like a caregiver or a patient. I think that's critical.
Hi, I enjoyed all your talks, so thank you. I'm primarily concerned with the quality of the data of which the artificial intelligence models have learned from and the potential flaws and biases built into those. And I was curious how you see CWRU's role in building models for the future ahead as being leaders in this field. And the questions for all the panelists.
I don't have an answer to that one. The School of Engineering has several, they have an entire department of data scientists who I think are thinking about this more deeply in terms of the logistics of it. For the medical school, we hired our first data scientist who's in the medical education office, and she's sharing with me just how dirty the data are. And so it does really help to just, I think there have to be some guardrails. I will tell you with our students, we have to have transparency when we're using it, and we're asking them to have transparency with us when they're using it. I think that's going to be the same thing for patients. And I think some of what Scott said about really understanding what data are the basis for what information is happening is going to be very key. And again, with full transparency so that somebody can dig in and say, oh, well, it's dirty over here. This isn't quite the standard that we expect it to be. I think it's going to be a learning curve. My hope is that we can slow down instead of speed up and actually start doing it more intentionally and methodically so that we can have good shared resources to really sort of collectively decide how we get the return on investment that we're looking for without creating new problems and biased issues.
I'd like to make a comment that I'm very pleased to say that Case Western is very proactive in developing programs and committees to look at this campus-wide. More so than I've seen in some of the other schools where we have large groups like the AI governance to develop and put out protocols for all the schools, working directly with engineering, working directly with the other schools in developing the things and the tools in the way in which we'd like to see, that would be best to progress forward. So I'm very pleased to say that Case has been very proactive in that, and I'm happy to be part of that.
And I'll just add, so one of the things I really like about Case Western is there are all disciplines represented. I come from a liberal arts background, and the reason I wanted to go to Case is because you have, your English majors, you have your medicine, you can have this opportunity to work together. So, the AI application I had was really for patient education, caregiver education. But data quality was an issue. So we actually had to train the AI on our resource book. And it was really important to us that that's what we use to educate or to train the AI, because I don't want to give wrong financial information to caregivers. That would be terrible. That's the antithesis of what I'm trying to do. But what I learned was that there is this balance that we have to think about. And I think this gets into this ethical applied area where it takes a long time to train AI to provide that information and education. And so my technologist was going, it would be a lot more efficient if you allowed me to draw on some other sources to help fill in some of the gaps that maybe aren't in the workbook. And so I think we have to think about a balance between, where do we need high quality, totally accurate information? Where are there spaces, and it's hard for me to imagine where this might be, where we can let loose a little bit and have a little bit more efficiency in our model. So I think we're going to need to have all types of thinkers to help address those challenges.
Hi, I'm Bob Bauman. I'm a child neurologist at the University of Kentucky. So this is for the professor of nursing. I was interested in that program helping caregivers. It sounded to me like that program was in California. I'd be curious where that stands. And the second question is, do you have a program like that in Ohio?
Yeah, absolutely. So I graduated my PhD from University of Southern California. They couldn't get rid of me. I kept coming back and collaborating. And so, so it's always good to be an alumni. And so I continue to work with them. We continue to put grants in together. And so that is a program that if anybody had interest, we could launch it again. The tools are available, so we would be happy for opportunities to do that.
So do you have a program that's ongoing here in Ohio?
No, we don't at the moment, but some of that comes from we just haven't found the right partner. So we should talk.
There you go.
He's in Kentucky.
Absolutely.
There's one right down here.
And then we've got one up front, too.
Thank you. It sounds like we're approaching, in the far distance, some sort of medical, dental, nursing AI utopia where AI will be able to do all these things and be all to everyone. But my question is, along the way, do any of the panelists foresee a time where we providers will be in a position to interpret the data that AI provides rather than to come up with the data? In other words, we'll ask the questions of AI, we'll get the answers back from AI, and then explain to our patients what it means.
I think that'll always be part of the conversation because, as Scott mentioned in his remarks, the context of illness is what, as human beings connecting with another human being, the robot doesn't see, can't process, doesn't have a heart or a soul to manage that. There's some interesting language in the literature about centaur versus cyborg. The centaur is sort of strategically bred to optimize the best of both halves versus the cyborg, which is the robot taking over and having much more weight. I think we need to avoid the cyborg completely, and we need to really think strategically of how that interplay between human and machine works to optimize patient care. And so my hope is that we'll always be in that position, because what a patient gets out of an encounter is not just a new crown or a prescription for a blood pressure medicine, but a human connection and a lifeline for their health and wellness. And that will never be replaced by a machine.
Hi, this is Abir El-Blouchi from Dubai. I don't have a question, but I really would like to share our experience back in Dubai. We are the first integrated healthcare system in United Arab Emirates. We have nursing school, dental school, medicine school, and we are epic. And we do have AI governors committee. We have 10 tertiary hospitals. We have 40 ambulatory. We have our own dental, I can call it hospital. It's a really big service. We provide care for Dubai. Dubai is very well known with tourism. We receive more than 15 million per year, plus around 4 million living in Dubai itself. So what we have done with AI is that we have AI Governors Committee, where I do lead the nursing. I'm the Chief Nurse Officer for Dubai Health, where we agree what AI technology will be implemented. I'll give you an example. In nursing, we have the AI charting, where I was able to say, I'm not ready to implement it in 2025. My nurses are not ready. In healthcare, whether you are a physician or a nursing, we do have generation gap. We have all type of generations. And the younger generations, which are Gen Z, are adopting AI faster than myself. So it's very important for any healthcare system to have a governors in AI and to allow caregivers and providers to say we are ready or we are not ready. I think this is the key because certain services, for example, dental might be ready to really apply certain technology while maybe imaging are not. So having really transparency and committee and providers to be sitting to say how do they feel about it, this is the key. We don't apply, especially that we are not a US healthcare system. Sometimes we think also about our patients who are Arabic speaking. My chart, for example, we had a lot of discussion with Epic. We need Arabic version of my chart. I cannot implement English version while my community does not speak English. So the message here is that providers, the users should be on the table when those decisions are done to say how do they feel about it. Don't apply it right away. Have a pilot. See how successful it is.
Thank you. Great.
Thank you. Very good.
Thank you. We probably have time for one more question. We have one over here.
Yes, thank you. As a practitioner, what you said about using AI for patients to get a response, for instance, about a slightly abnormal laboratory test, sounds like it works for me, except how do I know that the information the patient is getting is what I would want them to get? Is it what I would tell them? I think some study of that would be helpful.
That's happening.
On the other side of that coin, I'm sure the patient is happy to get information about their abnormal laboratory test, but I wonder how often or what percentage of the time they're going to want to get back to the practitioner to sort of get final approval or the practitioner's input about it.
Yeah, those are great questions, and I think what the data that I know for right now is that what they did is they actually took common medical questions from a Reddit thread, which is a social media networking thing, and they used doctor answers and AI-generated answers to sort of see what it was, and then they showed it to patients who had similar questions to get it. So it wasn't actually in the real space of taking care of patients. What Penn is working on is actually having all of those AI-generated messages back from a portal message from a patient actually blessed by the provider before it actually goes to the patient. So it may make more work because it's another checkpoint for the doctor to look at. But the hope and dream is that with machine learning, right, the doctor can really craft some of those automated responses before they are sort of automated and gone to the patient. So stay tuned. But I hear what you're saying, and I agree with you that, you guys as the people who've taken care of the wide spectrum of patients that are out there, some want every last minutia level of detail, and some want you to say, you're gonna be okay. And there's a lot of people in between. And so that's what I mean by the context of illness. At some point in time, we have to manage what meets the needs of the different patients, because they are different. Thank you for the question.
Thank you very much. And thank you to our panelists, Dr. Meyer, Dr. Pelak, and Dr. Logio, for their time and for their expertise this morning. And thanks to all of you for attending. At this point, we welcome you and invite you to attend our collaborative luncheon in the Cosgrove Courtyard. We hope that you will attend. Thank you again for being here this weekend.
If you are interested in CE credit, the nursing school is able to give 2 hours of credit. You need to access the QR code here. If you're interested in dental credit, you need to access the other QR code. This applies to our virtual audience as well. Thank you.